and I also would like to thank all the participants for participating in this very vital aspect of food and nutrition services in healthcare settings. Just a little homework. First of all, as Sarah has indicated, this is a 90-minute webinar. So the greatest task of the presenter is focusing on the materials as necessary and being able to share with you the points that are vital in understanding. So when we talk about quality initiatives in healthcare settings, we're referring to 483.75, quality assurance and long-term care, as well as 482.21, hospital quality initiatives. Let me say now that even though we talk about two different hospital and long-term care, when it comes to CMS, the Census for Medicaid and Medicare Services, there's only two distinct differences. Number one, long-term care is regulated and governed by state agencies for the CMS, Centers for Medicaid Services, and hospitals are regulated and maintained by Joint Commission. Other than that, both of them are required to maintain the same. They're expected to develop and implement effective, comprehensive, ongoing, data-driven quality programs that focus on systems of care. And so, in reality, what we're going to be focusing on today is the tools necessary for you to develop systems of care that will drive outcomes of care, which also determine quality of life. So when we look at these tools, we're going to be, again, focusing on 483 as well as 482 for hospitals. There is no difference from a standpoint of what CMS is expecting. The quality systems must be data-driven. Again, when we focus on the tools today that I'm going to be sharing with you, we're going to be focused on the collecting data as well as being able to create the systems of care that will give you the ability to be able to not just deliver, but measure quality of life when delivering food nutrition services. So our focus is strictly on the Centers for Medicaid and Medicare Services intent as it relates to the quality initiative, and that is to improve the care and safety of their nearly 1.5 million participants that are in long-term care and those that are in the healthcare system as a rule. So when we look at long-term care or hospital, it's a cause and effect related to hospital-acquired conditions dropping by 17%. In other words, since the system has been in place, CMS, I'm going to refer Medicaid, Medicare Services to CMS, has noticed a noticeable difference in the quality of care, as well as, and this is the bottom line when it comes to CMS, it's all about the money. If they can stop individuals from coming in related to food quality, and so quality is not just food safety, it's also residents making sure that they receive the type of things that, say, for instance, if they're diabetic or talk about high blood pressure or whatever the condition is, those are the things that drive them to from hospitals, long-term care, and so when their focus is there is no difference. And so one of the things, so as we go through our presentation today, we're going to talk about background, history. We're also going to talk about CMS new strategy, the new initiative that you'll be seeing over the months and years to come. A lot of you may not have heard about the measurable, meaningful measures But basically, this is the new initiative that is coming forward. You can go to cms.gov and learn more about this. There is no change from a standpoint of the guidelines and the things that we're going to be talking about today. But from a standpoint of process, CMS is looking for to be able to stabilize the tools and the quality of care that individuals receive related to this new initiative. So my goal is to share with you the background and the history and the strategy and how these new strategies affect your program. Again, even though it's great that CMS is putting these new programs out there, what I want you to be able to get out of this webinar and what I want you to be able to understand from a standpoint of the tools that we're going to share today is quality measures. So it doesn't, this whole webinar will be in vain if you don't understand that quality measures are actual programs or actual measures, or tools to help you measure quality of the healthcare process, focusing on outcomes, whether it be patient perceptions and or organization systems of care structure associated with that quality of care. What they're going to be looking for is if you're doing a great job, they want you to keep doing a great job. But it's not just good enough to say that you have a great program. They want to see improvements, goals that focus on efficiency, safety, patient-centered, we'll talk about equity, timing of care, and especially when we talk about long-term care, that resident that's going to, or that patient that's going to want something at 3 o'clock in the morning and they are declining in health, they want to know how you're measuring that. How does it affect the overall? So the existence of quality assessments and assurance, the QAA, revision of the 4283, specifically, it focuses on the QAA committee competition, a leader that is maintaining the whole program. And what I want you to know is that I'm not going to focus on the whole program. I'm going to focus on the department aspect, the food and nutrition aspect of how it is that you're going to integrate with that QAA committee person. So all facilities are required to develop and implement appropriate plans of action. And so when we focus on appropriate plans of action, we're focusing on the delivery of food and nutrition. And so as we focus on identifying, correcting quality deficiencies or issues, in other words, you're going to see as we share with you, there are numerous aspects when it relates to the quality assurance assessment, the evaluation process, as well as the quality assurance structure, the team itself, the process and procedures. And when we talk about process and procedures, meaning the food service manager, director carrying out the programs, how does it integrate with the cooks? How does it integrate with the frontline staff? So it's just not good enough that you are carrying out the program. When they come in and they look at your quality assurance, they're going to go to your frontline staff and they're going to specifically ask them related to organizational structure process that is going on and being able to carry that out. So the quality assessment assurance is a management process. And when we talk about management process, we're not talking about just the committee, but we're also talking about the department and how the manager or the food service department in this specific case. I'm not gonna be dealing with the overall of what the quality program related to the quality assurance for the whole facility. This webinar is going to focus on quality assurance and performance improvements in food and nutrition services. It is one of the most vital quality assurance programs because we all know that if people are happy with the food, they're pretty much happy with their care. So both involve information gathering related to the process of meeting quality standards, assuring that the care reaches acceptable levels. And when we talk about acceptable levels, which is important, we also want to focus on, when we say acceptable, meaning it's good that you're doing 90%, but what about the individual resident that you're not delivering it to them? Acceptable levels does not just mean that it's because you got good numbers. It also means that those residents that are complaining, how are you going to improve their specific quality program? So traditionally, relating to the requirements of F520, the quality committee comprised of at least a DON or a designated person. We're talking about overall now. The director, the medical director in that facility, and the specific department heads and or employees. So identify the quality issues, put together a plan. So if they're having a clinical meeting and they're talking about the weight loss, weight gain, they're talking about diabetics, numbers are being off, that clinical person as well as that medical director, they're going to be very well, I mean, that's we're talking about the clinical aspect. So there's a clinical aspect, and then we're also talking about the operational aspect. So the existence of the quality assessment and assurance provision related to the 4375, the program is designed and scope. The facility must design the quality program to be an ongoing, comprehensive, addressing the full range of services and care. And so when we discuss the tools in a minute, you're going to see, when we talk about full range, you're talking about not just the quality of the food related to receiving and cooking, talking about the aspects of delivery, you're talking about the aspects of the resident surveys or family relating to what the families are saying from a standpoint of the overall care. And when we get deeper into the program, you will see that we're going to address all these related to that. So food and nutrition and or hospital dietary program, the focus related to person-centered care. And so when we talk about person-centered care, you have a great program, and that's great. But if there are individuals that are not happy, we're going to talk about how the complaint system, how CMS, whether it be state and or national, can receive complaints, and those complaints are going to determine how they're going to come into your building and perceive your overall program. But it also must focus on fostering choice, no matter what the diet is, no matter what the time is, and no matter what, and focusing on that resident's preference sense. So the real key to me being able to help you to really understand where we're going to go with this is that you need to understand that there are no magic bullets. There are no right answers, and there are no one size fits all. So as we focus on the delivery and carrying out this program, what I want you to know, I want to be able to deliver to you the tools, and some of them will be quite new to many of you, related to some of the things that, and the tools are specific to food and nutrition services. So as we focus on these tools, and my goal is to support the nutritional well-being of all its residents, participants, patients, no matter what the level or is. So the focus is quality assurance, performance improvement, both in long-term care as well as hospitals. We're talking about a data-driven program that will close the quality assurance gap through evidence-based participation. And so some of the downloads that you already have access to, and some of the tools that we're going to talk about specifically, the 3, determination of compliance, the quality of care and potential tags. We talk about new kitchen sanitation observation. That's an actual CMS tool that you actually can use. In other words, you don't have to wait for them to come and determine whether you're in compliance. Use their tool. I do a combination. I have our own mock survey self-assessment tool, and once a month at least, I will use the CMS tool, because that is what, if they're going to come and find something, they're going to use their tool, and I want to be able to use that. The actual resident satisfaction survey questionnaire is part of this, but I also have included the Excel analytics generator. It's an actual Excel form that once you put the resident data in the into the generator, it would actually give you percentages, be able to show you improvements, et cetera, et cetera. Meal cart delivery, a meal cart confirmation, again, tools, hand auditing, some posters from a standpoint of, some basic generic things, a analytics generator related to hand washing, a time and temperature blank generator is part of the tools as well. So we have over 15 downloads that you have, including a PDF of this particular presentation. So as we, again, my goal is not to hash over already what you already know, but just to focus on the baseline of the requirements as related to participating in a Medicaid. If you are a facility that received Medicaid, Medicare funds, these are the requirements to participate. So we're talking about baseline care of each resident being performed within 48 hours of their admission, related to food and nutrition, member being part of the interdisciplinary plan. That alone in itself is a measurable tool from a standpoint of who is, how often, and again, many of you are already carrying these things out. These are just basic review, and again, tools that you can share with your staff when you go back. So the goal of the participants is to be able to develop, build, and or deploy their own data-driven QAPI systems. Also being able to, within your facility, create systems of care to prevent adverse events. Many of these tools that we're going to share with you, the goal is that you monitor anything that is below what we consider standard. Again, no magic bullet. What your residents or patients is happy with may not end up being an adverse event, but when they come into your building, meaning CMS, when they come into your building, what they're going to look for is and be able to create a body of evidence that show that that there are some things going on, or whether you have corrective measures in place and they are working. In other words, if you have a resident or customer satisfaction survey and they see the fact that residents or patients are complaining, but that you are addressing them, and that's all they require, that you have a outcome of care system in place. Fixes from a standpoint of corrections. Again, we will have these type of tools in place for you to be able to monitor and or be able to work these out. So the ability to deploy and build data points. So when we talk about a data-driven QAPI system, to be able to determine what data points are. In other words, if there are things going on in your building, if there are things that are happening that people are either not happy with and or that need attention, you must create a data point. and this requires a unit of observation. So when we talk about the unit of observation, we're talking about at any point. This particular, it could be based on monetary and or individual complaint and or individual different observation points in a given time. So I talked about it's great that we can identify that we're delivering breakfast on time, we're delivering lunch on time, but sometimes we have to be able to identify those patients and or residents that are complaining or have 5 smaller meals and or is losing weight and they require some type of meal delivered to them 3 o'clock in the morning. It's good that you would have some type of evidence-based data system in place to show that you are addressing those, if that is going to be a issue. But it is required, as in a regulation, that you have a quarterly tool that monitors these points and with the goal of preventing adverse events or increasing the consistency of the evidence-based practices. And so when we talk about, again, I'm being technical. I'm going to leave the technical aspect about halfway into this presentation, and I'm going to actually talk about the different tools. So our goal is that we have corrective actions and or what would be accomplished if that is necessary, what measures will be put in place, or what systematic changes will need to be made, i.e. adding personnel, i.e. adding delivery times, those type of things. And then monitoring, ongoing monitoring. So typically speaking, when CMS comes into your building and they determine that something is below compliance and they issue, they issue you a 2567, there is a reg that says that you have to have a tool in place that show that you corrected it and it's at least monitored for 3 months to show that it was corrected. So the plan related to monitoring and ensuring the deficient practices will not occur again. So the quality initiatives are required to maintain. So when we talk about the quality initiatives, we're talking about that data point. How do you collect that data that show that this particular aspect has been achieved? The necessary systems, the management standards. When we talk about management standards, we're talking about policies, procedures, practices. Those are the type of things that managers are responsible for maintaining. So, and then what qualifies as a data point. So again, related to the corrective action, what measures, how to monitor it, focusing on the deficient practice from a standpoint of that it will not occur. That is the focus of the quality program. So again, I have here on the, again, it breaks it down in your PDF a little better than the presentation itself. But this was an Action 2567 that was issued to a healthcare facility, long-term care, and it focuses on meal service. The dietary staff will contact, in this particular case, it was a delivery issue, and the nursing staff being informed on what's available, what time the carts and et cetera, were in place. So there was a requirement that they had a means of being able to measure this. And it just so happens that we have one of the tools that will address this. So in this one here is a actual hospital tag focusing on the corrective action that will be accomplished, what measures will be put in place, the systematic change that are necessary, again, how will be monitored to ensure that deficient practices will not occur, and the quality assurance program. Again, I'm not going to focus on the actual deficient practice itself, but I'm focusing and make sure that you understand the corrective action that's necessary to accomplish it, and then there needs to be some means of being able to measure, put in place a systematic system. And again, some of the tools that we're going to talk about in a little bit will be able to help you with that. So the actual ability to be able to formulate data points, again, we're going to talk about that specific aspect. That's one of the things that we're going to talk about today and when we get into our actual presentation. So able to develop and deploy observe data points. So in the F361, in this particular case, we talk about staff, and the facility must employ sufficient staff with appropriate competencies and skill sets to carry out the function of the food nutrition services. Again, this one specific data point we're going to focus on, and we're going to actually show you one of the tools that we're going to use to be able to show a bit of the sufficient staffing and or focusing on resident assessments, individual care plans, the number of acuities, all those individual things that are necessary. So observation and 48360, the qualified dietitian, again, these are all observable data points. Support staff, the facility must provide sufficient support staff to ensure safety and or effectively carrying out. This one is actually really interesting. And when we talk about support staff, we're actually even talking about CNAs and or medical assistants. And if you have, in the case of a hospital, candy scribers and or activity staff in long-term care, we talk about sufficient support staff. This means that the observation and or training that is necessary for these individuals to efficiently, safely carry out that food and nutrition actually is responsible for ensuring that this process is being carried out, and that, again, you would have a tool that shows that you're doing that. And again, ability to be able to deploy and build F367 menus with nutritional adequacy, meeting nutritional needs of individual residents according to national guidelines and or prepared in advance. And in other words, we sometimes put select menus in place and or a resident that we know that has a specific thing, or in this particular case, a resident that and or individual that the food went to the floor, they didn't like it. There needs to be the ability to make sure that that food is brought back to that patient and or resident on a timely basis. Being able to determine that how long does it take, and then have some ability to observe and create a data point for those. 4360, reflecting on the facility's response efforts and efforts related to religious and or cultural and ethnic needs of the individual resident. And so, again, these are all data points that we can create. And so, even though I'm sharing with you some very basic tools, as I share with you the tools, a lot of them that can be adapted to create and or to be used to build and or deploy some of these other data points that I'm talking to you about now. Food and drink, each resident receiving and facility providing, especially in long-term care. It used to be very standard for us to say we don't serve Cokes or salt drinks, the family provided. In this particular case, under the new regs, it actually says that the food and drink received by each resident and facility provide is one of those things that will be measured. For food paired and methods to conserve nutritional value. Again, this is an observation point. Food and drink in palatable, attractive, and safe, appetizing. One of the real sticker points on this one in the morning, juice. Residents complaining that the juice is warm. This is an easy tag for food or drinks not being palatable and or attractive advertising temperature. Again, another observation point, 366. Again, many of you already know these. I'm just pointing out the fact that these are observation points that can be actually put into a data or QAPI type program. Therapeutic diets, again, easily measured from a standpoint of what you're offering, how many each of them, would be diabetics and or low sodium, how many diets that you have. And this one also is very important from a standpoint of you knowing those numbers, because when a new patient and or person come into your building, you have to be able to determine at any given time, from a therapeutic standpoint, how many people that you had on each of the diets. Those are observable data points that they would be interested in. Again, if it never comes up, and this is never a complaint, these data points, all of these data points that I'm mentioning to you, are not necessary. But if it is a correctable issue that is going on in your facility, you need to be able to deploy and or build these data points. Here, 4360, 3 meals a day, regular times, but you also being able to meet a resident's needs who don't eat in those times. Meals being served 14 hours between. Again, most of these are long-term care, but we also have in the packet hospitals, and we're going to touch on hospitals as well. When you'll see on the bottom here, talk about this particular one is one of the ones that is on that CMS is going to ask your either patients and or residents directly whether you find the food suitable, nourishable, and whether you can get an alternative meal and or snack when being served. So this is an actual question that they will actually ask your resident population. So what are the policies, procedures that may need to be reviewed? So when we look at the list and we see an inadequacy, what it might bring to your attention from a standpoint of what are the questions that need to be asked related to how you're going to build your QAPI program. What policies, what procedures need to be reviewed in order for you to be able to correct these things? What policy and procedures need to be modified in the review process? You're only required to do it once a year, but sometimes when you're getting complaints, you might want to review it and find out what in the policies and procedures need to be changed or modified. And that's one of the things that they're going to want to be able to see too. Did you change the policy to address this? Will this involve staff training, in-servicing? If so, the correlation between the performance of the staff before and once the training and or in-service took place afterwards is a observable data point. Does involving or creating a new position? We talk about the nutrition aspect. Does it require you to add somebody on to do just that one thing? When it relates to staff training and or in-servicing, with all of these new policy procedures, did it require you to add someone? So what time does it need to be completed in? Again, these are questions that you should be asking yourself before they come into your facility. So the tools to meet the challenge. So measuring outcomes of care and quality of life, the gathering of information related to the CMS aspect, actually dependent upon whether you are a long-term care facility, an assisted living facility. Again, most assisted living facilities don't receive Medicaid, Medicare funds, but if you are in a unique situation where that is taking place, they either are going to do the traditional paper survey and or the QIS survey. I prefer and I like working on the QIS because basically what happens is when they come into my building and they go through the first 9 steps and I meet all the criteria, then what that means is that that dietary or the food and nutrition department meeting those guidelines, they could be in the building for the next 3 months. Their focus will not be on food and nutrition. So the actual potential negative outcome is basically, whether you're talking about paper or the QIS system, is that they're looking from, talking about the failures of the facility or your systems that you have in place, and or that you're not assisting and or helping residents and patients achieve their highest level of participation and or well-being. So those are the measures that when they come to your building, they really aren't interested in your program. They want to know how does the program affect and or the negative outcomes of a particular aspect of it, and that the patients and or residents are achieving the highest level. This particular tool you also have in your packet, and being able to compare the difference. Why is it important that you understand the difference between the traditional survey as well as the QIS? And again, I've already identified the fact that in the QIS, each team member uses a tablet. They go through, they determine the number of people that are going to be surveyed, and you get the results almost immediately. Whereas in the paper traditional system, it is a longer process, but it basically is the same outcome. So when it relates to the food quality trigger, there are actually 51 different areas of care, 128 quality of care and indicators of life. So when we talk about food quality, the one specific one that they will focus on when they come into your building is 65 QP 249, and it focuses on the food quality, a resident, and it focuses on resident interviews and or complaints before they come into your building. Again, so when we compare the traditional versus the QIS system, once they go through these particular interviews, if your facility related to food and nutrition meets the national standard, which is a 33.3, food being palatable, then basically you won't be part of the phase 2 of the process. So, but the quality indicator process actually starts before they come into your facility. The OSCO program, where patients and or residents are given the ability to be able to lodge their complaints. This process, they actually have the online survey certification process, whether it be long-term care and or hospital. CMS, the complaints registered through the system are passed on through the state agencies, contractors, hospitals, dialysis systems also. In other words, these individuals are able to lodge complaints, and I focused on dialysis center because oftentimes we send lunches out with our patients, and if you are sending out meals that are non-compliant to their diet, they actually can lodge a complaint. And, you know, they should also give you the courtesy of letting you know that this is something that is working against the particular patient, but just know that those type of things, they should be measurable, and you should be able to know that. The Ombudsman's office related to, again, the state ombudsman, past resident complaints and or resident council, they also, so these all are ways that they gather information before they actually come into your building. Again, the OSCO system basically gives them a percentage, and based on that percentage, they determine how they're going to enter your building. So this is what you need to know. Related to the quality assurance process, they only are coming to validate. They're not coming to see whether you're good or bad. They're validating whether residents are receiving or patients are receiving the proper care, whether the complaints are valid or not. They will investigate every single complaint. And sometimes if the complaint is bad enough, they will actually validate it before they even come before the survey process. But whichever way it is, when this process, we talk about quality assurance, they are only coming to validate. So the QIS, two-stage, meaning computer assisted, again, as I said to you before, the stage one, they compare the information that they receive off-site, and then the data that is entered into the computer by collecting the surveys, whether it be from residents and or staff. They gather a sampling. They don't check the computer actually gives them the sample. They don't get the resident that complains all the time or the patient that complains all the time, they may not be part of the sample. But know this, that even though they're not part of the sample, if they have a complaint, at the end of the phase one process, they actually will go to that resident and determine. When I say resident, I sometimes forget to say patient, but those that are in the hospital setting, I'm meaning the same. But they will also include the input from those individuals related to this stage one sampling. So stage two is now that they've determined that you didn't meet the national threshold, and they must further investigate. Now, this is where your tools are critical, whether it be collecting the time and temperature, whether it be focusing on a resident survey. Even though you didn't pass the national threshold, and they start to investigate. Now, this is the time when, if you had your quality assurance program in place, even though you may not have passed the threshold, this is where you may not even get a tag because you have evidence that you had an ongoing program. That is critical to the reason why you're on this webinar right now. The goal is not that they're going to find something or not find something. It's whether you have an ongoing verification reporting process in place. So the investigative protocol related to violations and or complaints, resident dignity, resident rights, ongoing issues, the quality assurance indicators, in this particular case, food, will focus on the sampling of the residents. They're saying that the food doesn't taste good, or it's not appetizing, or that the temperature is not proper. Again, all these things can be remedied if through your quality assurance program, and those are the things that we're going to talk about. So when we talk about the quality assurance process, we're talking about in food service, it starts before the team arrives. Know that they are only validating what related to the national threshold. But you determine, or your self-assessments, the tools that we're giving you, you determine what they're going to find. You should not, a surveyor should not be able to come into your facility and tell you that you have something wrong. As a matter of fact, if they look at when they look at your quality assurance program, they look at the fact that you have a ongoing assessment related to a particular program or problem, and you have a tool and you have a way of being able to measure these. And by the way, a lot of the tools that I have created came as a direct result of some of these very complaints, some of these very things that we're talking about now. So I can just make up tools. These are tools that were actually made. And so when we go back to, you look at my background, 18 years in long-term or healthcare food service, and out of those, 12 years of them deficiency-free. So how is that possible? Because their process that they have in place, the QAA process, the QAA tools that you have in place, being on that committee, these are the things that assure them that even though you might have complaints, that you have tools and processes in place necessary to correct the problem. So the verified reporting, the sampling of the food and nutrition process, these are programs that I recommend that you have in place, and they are done at least quarterly. Now, when it comes to the resident survey, I recommend, because your population changes so much and your residents change so much, I recommend it at least once a month. Menu satisfaction, cart delivery times, dining room surveys, critical. Even though you have an ongoing, you want to have, when we do the resident survey satisfaction, I'll show you that tool in a few minutes, we actually break it up so that you can break it up by unit. So that resident A, that survey that's done blindly, and typically I don't allow the dietary staff to do it, but it could be a project for the dietary staff. But if that's the case, you want to be able to break it up so that you can show that that you would have a survey for dining room A and for unit A, and we'll see that in a few minutes. Talk about time and temperature, refrigerator temperatures. We're talking about line temperatures. We're talking about delivery temperatures, test trays that will that determine what the temperature of the food when it was delivered. And of course, those of you that understand the test tray process, you don't do a test tray when it gets to the floor. You do the test tray once the last tray is delivered on that floor. Cook line temperatures, tray accuracy reports. Again, all these things are part of your quality assurance package that we have given you. And then hand washing studies. Again, all of these are quarterly. I recommend it to be quarterly projects that you actually can do from a standpoint of making sure that you are measuring and or that you have the tools and things in place. So measuring the right things is the focus here. And again, when I'm mentioning to you, there are no right answers, there are no magic bullets. But I can tell you that if you have these tools and you are using them, whether it be your mock survey and or your audits that you're performing, whether it be quarterly and or monthly, and I say the mock surveys I would do at least quarterly, but when it comes to the audit tool from CMS, you should do that yourself and do that at least once a month. And so what you want to be able to do is it will give you a month-to-month guide on whether last month what that total was versus what it is this month, and then it might tell you that you might need to do a special project. So the one that gives the people the information and the freedom that they need to realize the potential within their own individual facilities. And again, when I focus on the right tool and the right measures, it is an individual facility process. So when we talk about measuring the right things, it's in the messaging. So the quality assurance or the QAA process created a heightened or improve the messaging around the specific issues. So notice here, all of our messaging related to most of it is either formal or informal. And so when we talk about the messaging, we talk about most of the learning related to the assessments and or corrections. The 70% of it is actually formal messaging, policy, procedures, processes that you have in place. But what you want to be able to do is be able to create messaging related to, so for instance, it's not just good enough to have that your staff know. Well, we talked about CNAs. We talked about the volunteers that are in your building. So you want to create quality assurance projects that include formal and informal messaging. So when we talk about right message, we want to make sure that we have customer satisfaction related to, again, the customer, whether it be hospital and or long-term care. And when we talk about customer loyalty, we're referring to the fact that some of them are long-term, and your results are going to be dramatically different. And I point this out specifically because once we got into, I took over one very troubled facility, and in this particular troubled facility, when I first got there, the residents complained vehemently about the fact that they would complain about whether it be the temperature or not getting what they needed, and nobody was listening. But when you have a great quality assurance program, you create loyal patients and customers. They wanted to know, what did we do to the residents that they're not complaining? And what we were doing was that we were not just taking their complaints. There were measures in place to ensure them that we were complying, not just to regulatory compliance, but also we talk about brand loyalty, your specific facility and or your corporate brand. From the standpoint of, you might have a facility that is, multiple facilities. That way you compare what you're doing versus what other facilities are doing. But quality assurance is critically important. When we talk about information gathering, we also talk about benchmarking information related to standard practices, measurable objective, corrective actions. In this particular case, hand washing is one of those great tools that create a benchmark. And so what I typically do is that when I do this, I don't do a broad range of surveying, did you wash hands? There's an actual observation, just the cooks for 3 days, just the line staff for 3 days, just the dining room staff for 3 days, and then use that information to create it as a benchmark from a standpoint of the progress that you're making. So in this particular case, I say that you need to do a hand washing survey and analytics at least once a quarter, and then you'll be able to use those results. Again, you should not want a surveyor to come into your building and then find that you're not doing certain things. And the way that you do that is that you have done it yourself. They're going to be observing whether residents, whether your employees are hand washing. So you want your staff to know before they get there that what are the observations based on whether it be, their discipline, cook, line, et cetera, et cetera. So part of the information gathering that CMS carries out is, and this is part of your package, the resident satisfaction survey, the basic 6 questions. How would you rate the dining service? How would you rate the quality of the food? How would you rate the temperature? How would you rate the variety of the menu? And again, the very same way that they ask excellent, good, fair, when you see the survey tool, the tool that we're going to give you, it actually in that same way, and you can get measurable results. So again, information gathering relating to cart delivery. Again, this is a great tool. I put this tool in place because what was happening was, even though we had a cart time, the carts were being delivered, but they got to the floor and then they were just sitting there. Well, it wasn't the fact that they were just sitting there. It was the fact that the residents were complaining that the food was cold. And this is one of those formal and informal information gathering things. This information now was used to show nursing staff, CNA staff, that the carts were being delivered, but it was taking 20, 30 minutes for the food to be delivered to the residents, resulting in poor temperatures, poor quality of food, residents complaining. So this tool is absolutely vital. Again, if you have a problem with cold food, start with cart delivery confirmation. And again, this is a standard HACCP form. We take the standard HACCP information and then put it into an analytic tool that gives you, and again, this is the, so in this particular case, we do test trace, breakfast, lunch, dinner, and then testing the main starch, milk, coffee. But notice in the bottom here, we have average line temperatures for all 3 meals, whether it be the main item, starch, and we have a tool in place that actually will allow you to put those things in and then give you a, again, the surveyors love this tool because what it does is it shows them that you are proactive. It's going to show you that you have a problem, whether it be breakfast versus lunch versus dinner, and then that you will have an ongoing process of why and then how you were able to correct it. Related to staff training and or the survey process, again, this tool, again, that you have in your package, these are standard, but it'll give you the ability to be able to change the items. This is a Word document, and then what I would have is my staff, and then be able to, and this again, this is a measurable tool to be able to allow you to measure who has compared where this person is versus another person. Again, it's another great tool. Again, this is about quality assurance and performance improvement. Again, it's not just good enough to say you're doing it, but you have to put in place corrective actions or preventive action plans. And the CAPA programs that, again, you have, again, this in your package as well. So the preventive action is a way of implementing and or addressing weaknesses in your management system and or your systems of care. Again, that's what they're looking for. It's not good enough that you have a great program. They want to know that you have corrective actions in place that focus on these. So a good quality assurance and a program will always include corrective actions and preventive action programs. It will focus on root cause, focus on the correct action plan and the actions that you took to focus and or fix those things. In this particular case, the taking, and we want to have a formal what you had in place, talk about the problem, the action taken, and the resolution. And, you know, would you want to, at some point, put some value to where one person is, if this was, say, for instance, breakfast versus lunch versus dinner, or, and when we talk about not just the delivery, but how about if it's the cook? That's the issue. This tool will be able to give you and be able to be used even in your annual review process to show that your corrective actions are taking place. And then once all of these are done, once you have the information, you want to be able to communicate the outcome to your staff, communicate the outcome to your team. We're talking about the QAA team, but we also want to make sure that it's passed on to nursing, passed on to those other individuals as to why once that cart or that tray gets to the floor, why it's so critically important. And the ability to be able to identify the main dining room versus cart delivery, whether it be breakfast, lunch, or dinner. And let's talk about weekends. We know that staffing is different on the weekends. These measures will show you in this particular case. Again, so with these type of tools in place, you can see why the survey team will be excited that, and they're not used to going into a facility and seeing this type of detail, seeing this type of communication, formal and or informal. When we talk about the QA process, typically speaking, you know, they'll see a book and, you know, where all the information is, but that communication should also be passed down and communicated to your line and or individuals that are helping to carry it out. Again, what you want to be able to recognize and or understand when it comes to this process, that when CMS is coming into our building, all they're doing is coming to verify what it is that you're doing in your program. And so when we focus on the verification process, we're talking about the quality indicator processes. No one should be able to come into my building and tell me that my residents are complaining. I should already know, and I should already have in place, when they're talking about a good quality assurance program, I already have written programs to show that that I have an ongoing process in place. And again, we talk about the verification process, talk about quality indicators. It works. And what it's going to do is that it's going to create trust. And we talk about loyal customers. We talk about a brand related to the dining, the food and nutrition process. The goal is, like I said to you before, when CMS comes into our building, there should be no, they're not coming there to say, I got you. They're coming to measure how your patients and or residents trust the quality assurance related to measuring quality assurance when it comes to food and nutrition. It's an important aspect of the quality assurance indicators. And again, when they come into our building, we want to be prepared, because what we know is that they're coming to validate. So now it is a possibility that once they go through this information gathering, whether it be because they received it from the outside sources or they measured your patients and or residents, that their validation might include something totally different. And that's why, and that's where, if you have a good quality assurance program when it comes to the food and nutrition program, what it does is that it shows that even though what they received, that sampling that they received, it was a snapshot, and it may not end up being a reflection of your overall performance related to the quality assurance process. Now, so now when we talk about the CMS and what it is that they're looking for, the interpretive guidelines related to the quality assurance process, the overview, talk about encompassing all the management, administrative, clinical, and environmental, talk about the performance of the contractors, et cetera, et cetera. When it relates to what they're looking for. We talk about they're going to measure all these things. And what they want to be able to do, they want to be able to come into your facility and determine, whether these things are, when we say working, that's the reason why CMS put these things in place. That investigative aspect, whether it be in long-term care and or hospitals, the preparation necessary related to the determination of compliance, routine and non-compliance, and then the actual quality aspect. Again, all these things determine whether you are in compliance. And it may not be the snapshot that they took. Related to hospital, again, the process, and because hospitals, in reality, there is no difference, but because Joint Commission, their wording might be different, their tags might be different, but the outcome, as far as the conditions of participation, are actually exactly the same. When we talk about the tools that we're sharing with you, these tools actually give you the actual same result. And again, the tags might be different, but related to hygiene or hand washing, talk about sanitation guidelines. Again, when it comes to the tool that they use, it's exactly the same tool, but it is applied differently because the QAPI process in a hospital is set up different. But from a standpoint of the dietary department and/or food and nutrition, the outcomes and how you deliver and or give those to your team are actually pretty much the same. So there are 14 potential quality tags. Again, I'm not going to review those because I gave them to you in your packet. I would focus on creating, especially if you know that these are potential tags, that you have in place tools that will actually measure these. So the new, in your packet, the downloads that you have, the new tool, so with all the changes that took place in 2016, CMS retooled, changed their food and nutrition kitchen observation tool. You have that in your packet. Again, you want to do that at least once a month. And so, I'm sorry, the 2017 tool. The new dining pathway, again, the same. This tool is absolutely excellent. Every manager, every food and nutrition or dietary department should be using this tool because this is exactly the same questions that when CMS comes into your building that they're going to be looking and applying. The mock survey tool that I referred to you, that you should be doing this tool at least once. This is a tool that I created myself that helped me to be able to, even though CMS had their own tool, from a broad-reaching, being able to address and or corrective measures, when I did it, how I did it, you know, being able to have a tool right in hand to show that we actually dealt with that aspect. And this is, I'm gonna turn this tool into my QA team as well as the analytics that go with it. The questionnaire, the resident survey, again, exactly the same questions that CMS is going to ask. If I want to minimize the risk, I want to know what my consumers are thinking. I want to know what they're going to say to CMS. I don't want, you know, in other words, if I have a resident that's saying something different, I want to be able to show that, you know, we, on a monthly basis, we did the survey, and this was the outcome. So let's talk about the resident, that even though your points might be well above the national standard, but you got that resident says, you know, they are very unhappy. This tool is exceptional. I always give the example of, we sent out a select menu, but this one particular resident, she still complains, and all she always checks is a cheeseburger. Well, the fact that you sent her a select menu and gave her options and sent someone to her room and she put cheeseburger, that document invalidates, even though she complained. So when they come and say to you, you know, everything went great, you passed phase 1 with flying colors, but what about Miss XYZ? And then you're able to give them the information, show them that you sent that select menu, that you sent the resident survey, and even though she was complaining, she always went back to that one item. So that when we talk about the toolkit and the analytic generator, these are actual Excel forms that you can put your own, you can correct the information from a standpoint of how many units, how many, you can put that information in, and it would actually give you the analytics related to your individual facility. So those are included in your download from a standpoint of your tools. Again, CMS they want to be able to see at a glance the quality of food, hot food served cold, the variety of food, snacks being offered, substitutes being offered. They want to be able to see it, and I'm going to tell you, even though your snapshot is showing that your residents are complaining, when they see this and they see that you are actually doing surveys, this is a quality issue. This is what they want to see. And this assures, even though the snapshot that they're having when they come into your building may not be accurate, when they see what you have, and the likelihood is you may not get a tag, you might get a mention, and then the fact that, you know, they were satisfied with that you had an ongoing program. Again, we talk about the test tray program. So we have a tray accuracy as well as the test tray form. Both of these are that you're receiving. And then I've also given you a sample of, you know, being able to break down the analytics into a report that you can pass on to your team. It is important that communication. It's one thing to do the test tray, gather the information, do the analytics, but you've got to be able to pass that information on to your team. Again, the test tray analytics as well is in your packet. So the cart delivery, again, the tool is the form, again, in Word format, and it has an analytic generator on this particular form as well that is included. And then, so being able to break down each dining room related to delivery and or service. We actually did test trays. So once every resident or patient was served in that dining room, we actually, meaning the main item and or the alternate item, we would have them, the cook and or server, do a actual tray once everybody is served, and put that up there and test the temperatures, taste the food themselves, and that would be used to generate the test tray for given meal. Again, it's critically important because what's going to happen is that when residents are complaining in that dining room, and what happens is, in this particular case, and excuse me for going back, in this particular case, when we do the test tray form, it's going to give you what was the item served on that day, what is being served, what was the temperature. And so in that dining room, being able to do a test tray analytics will indicate what was being served in that dining room. It's critically important because it's a record of what was served, what was the temperature, et cetera, et cetera. Critically important. And again, one of the reasons why you're going to get a positive outcome every time. So the cart delivery analytics, again, in this particular case, I was able to put the times that was supposed to deliver in from the reports. Now I'm going to put the time it was actually delivered. It's going to give me, I can have at a glance, I will be able to see and why this was very critically important. I always saw that the dining room, the dinner time delivery was always on time, always in line. I wanted to know why was it that they could do it and whether it be breakfast and lunch couldn't. And you know, this is a good exercise because the truth is that the breakfast person has less time to do preparation, et cetera, et cetera. So sometimes they do shortcuts. Sometimes they don't bring the food up to the proper temperature. And so what is going to be the outcome? How did you correct it? So again, this tool is critically important to be able to bring out those things. Again, the hand washing analytic tool, it's important that you understand this tool. It's easier and better to apply if you do cooks and then line and or a specific dining room by observation, how many times they wash hands at critical points, and then be able to break it down. Again, when you see the analytic tool, it'll be able to break down and show you. And again, you will have the ability to alter this tool and to be able to, however you want to be able to do your information gathering and use this tool, you will be able to change that up. The master food temperature tool, again, you will have in your package. Staff annual training, again, we talked about this one, but how about adequate staff. Again, I have a tool in place that will allow you to put your staff and then show what position they were, to show that each position was filled on each shift when they were short. This tool, again, it will be able to show and demonstrate that you were properly staffed and when you weren't properly staffed. If, you know, breakfast staffing was inadequate or dinner was inadequate, again, these tools will help you to be able to determine and or show that you have an ongoing at-a-glance program. What I loved about the tool is I did my schedule by the month, so therefore I was able to do the report once I did the schedule, or once I did this tool was complete for the whole month. When there was a change, we put the changes in, and then it became a permanent tool or report. In your package also, you'll have all the new changes related to food and nutrition. An excellent tool that was done by Crosswalk that is included in this package, being able to explain to you the new tag numbers versus the old tag number, and if there was any changes related to that specific tag. Again, some of the references and or things that are included in this particular program, upcoming webinars and or projects that we have coming forth. Again, I want to thank Compliance QI for the ability to be able to make this presentation. I pray that everything was presented in a way that it was understandable. At this time, we're going to open up for questions. If there are any questions that you want further clarification, you also can forward those to Sarah, and we can answer them from that standpoint. Sarah, it's back in your hands.